السلام عليكم ورحمة الله وبركاته. مرحبا بكم طلبتنا الأعزاء، المرحلة الخامسة. نتمنى لكم الصحة والعافية والسلامة من كل شر ووباء، ونسأل الله تعالى أن يحفظ بلدنا من هذه الغمة، وإن شاء الله الزول بإذنه تعالى. Our lecture today is a postpartum hemorrhage. The postpartum hemorrhage is very important subject. It is still the major cause of maternal mortality and morbidity in all over the world, even in the developed country. That's why this lecture is very important. You must know all of the things included in this lecture must know by the students. Yes, the learning objectives of this lecture: the student must know the definition, must know the causes, must know the diagnosis, and must know the management, and must know the prevention. All of the things included in this lecture must know by the student. The contents is the definition, causes, treatment models or methods, types of retained placenta, and the degree of perineal and vaginal lacerations. Okay. We started by the major causes of death for the pregnant women. Maternal mortalities account for the postpartum hemorrhage in about 28%. It is the major first cause of maternal mortality. And the second is the heart disease, and the third is the pregnancy-induced hypertension with amniotic fluid embolism. And the last thing is the infection. Okay, it is the first major cause of maternal mortality. Okay, واضحة. What is the definition of postpartum hemorrhage? Be defined as the blood loss exceeding 500 ml after vaginal delivery of the infants. When the blood loss exceeding 1000 ml after cesarean delivery is account for a postpartum hemorrhage. Okay, then the type or the mode of delivery is important in order to decide whether it is a postpartum or not. When it is 500 ml after after vaginal delivery is considered to be a postpartum. When it is more than 1000 ml, account for 2 pints of blood, it is considered to be a postpartum. And we classify the postpartum into two categories. The primary postpartum hemorrhage, when it is occurred in the 24 hours after delivery, within 24 hours after delivery, and the late postpartum, when it's occur after 24 till the 6 weeks after delivery. And we have another category which is not present in this lecture, but it is maybe heard by someone. The immediate postpartum, when it has happened 1 hour after delivery, and that is to say in the beginning of the 4th stage of labor, which is 1 hour after the 3rd stage after delivery of the placenta. Okay, and then we have the immediate and the primary and the late or secondary postpartum hemorrhage. Yes. What are the major causes? We have 4T. We have the atony, account for 90%, and we have the tissue injury, second T, it was 6%, and we have the tissue retained. This is genital tract injury, trauma, and the tissue retained. Okay, retained placenta account for 3 to 4%, and the thrombin, which is the coagulation defects, account for blood decreases the rest of the percentage. Okay, then the major cause هو التون اللي هو 90%، والسكند major هو التروما 6%، والثيرد هو التيشو retained placenta 3 to 4%، والثيرد هو الثرومبين deficiency اللي هو account for the rest of the percentage. Okay, then uterine atony is the major cause of the postpartum hemorrhage, account for 90% of it. Okay, we started by uterine atony, which is account for the, as we said, which is account for the 90% of the cause of postpartum. We have local factors, the causes of the uterine atony. We have local, we have systemic. What are these local factors? When there's overdistension of the uterine muscle or of the uterine cavity because of hydramnios, multiple pregnancy, and macrosomia. Okay, and the second, conditions that interfere with the contractions like leiomyoma. When there is a mass within the uterine muscles, it will interfere with the uterine contractions, retractions. It will lead to uterine atony after delivery. Complications like pregnancy-induced hypertension, anemia, and placenta previa. All of these may lead to uterine atony, which are account for local factors, lead to postpartum hemorrhage. The other, we have a systemic factors, systemic like nervous, like any person with myasthenia gravis, and other neurological factors may affect the uterine contractions, retractions. The others, drugs like magnesium sulfate and sedative. This will lead to interfere with the uterine contractions and lead to uterine atony. Abnormal labor, whether it is prolonged or precipitates. The labor, when it is prolonged or when it is fast, when it is precipitate labor, all of these will lead to uterine atony. History of previous postpartum accounts for about 40% of the another postpartum hemorrhage may happen in the next delivery when it has happened before. Preeclampsia and abnormal placentation, like placenta accreta and others. Okay, we will discuss this later with the tissue. Okay, then we have local and we have systemic factors related to causes of the uterine atony and postpartum hemorrhage. What is the pathology? How the uterine atony happened? When the uterine muscle contracted, it will lead to constriction of the spiral arteries. You know, the placental bed is a large placental tissue and it is highly vascular and it is associated with large sinuses in order to carry the blood supply to the growing uterus. When all of these are opened after the delivery, it will lead to postpartum. When the contractions happen to the uterine muscle, all of these spiral arteries and sinusoids will be constricted. When constriction happens, the blood loss will be less and the postpartum hemorrhage cannot be occur. Preventing the excessive bleeding from the placental implantation site. When uterine atony is happened, this will give rise to the postpartum hemorrhage with no contractions occur. You understand? When there is uterine contraction, when there is no uterine contractions, or when there is a uterine atony, this will lead to postpartum hemorrhage because no contraction occur. That's why no constrictions of the spiral artery will be occur and the bleeding will be more. And this will lead to a postpartum hemorrhage. Prevention and therapeutic of the uterine atony and therapeutic applications or therapeutic methods for the uterine atony. All of the things or all of the priorities will take in order to increase or enhance uterine contractions. How we enhancing? We can enhancing by mechanical stimulation, we can enhancing by administration of medicine, we can enhancing by the others. So we started by the administration of the medicine to promote uterine contractions of the uterine corpus and decrease likelihood of uterine atony. What are these drugs? We have three major drugs. We have the oxytocin and we have the methergine and prostaglandins. All of these uterotonic drugs will be promote the uterine contractions of the uterine corpus and this will lead to decrease the postpartum hemorrhage and decrease blood loss. The prevention it is usually better than the treatment. So be aware of the risk factor, and any patient have risk factor, we call it before. We must be aware about these risk factors. May present antenatally or intrapartum. We must treat the anemia antenatally. The treatment of anemia is very important in order to make the women more liable to face the bleeding. She can't tolerate the bleeding when it has happened. When she is anemic, she cannot tolerate even so small blood loss. Okay, and the active management of the third stage of labor. All of these will decrease the likelihood of the postpartum, which is caused by the uterine atony. And we give, how can we make an active management? We mention it, if you remember, in the lecture of the stages. When we discuss the stages of labor, we want to discuss the third stage of labor. We discuss the expectant and the active management, and we call it the active management will decrease the amount of blood loss into about 40 or 70%. Prophylactic oxytocin reduce the risk of postpartum by 60%. Oxytocin and ergometrine, okay, and we given in multiple modalities. Can we give 5 international units of oxytocin IM for vaginal delivery and 5 international unit IV for lower segment cesarean section? Because you cannot give the oxytocin IM during cesarean section. We give it IV, but in the vaginal delivery we can give it IM, because with the IM injection is better for the increase the duration of action when we give it IM. Okay, when we give it IV, the duration of action is less, but there is no other method to give it during cesarean section. And we may consider oxytocin infusion if we need more contractions, for we give it as an infusion. In the both of them, we can give it as an infusion in the vaginal delivery and in the cesarean section. After we give it the 5 international unit IM and IV in the vaginal delivery and cesarean section in sequences. Okay. How can we do when we develop such a problem in the labor room? We started by resuscitation. How can we resuscitate the woman? We can resuscitate her by ABC. ABC is very important. Airway, blood, and circulation. Okay, we number 1, we give it oxygen by oxygen mask. Okay, and we put a wide bore cannula, two wide bore cannula, and then we take a blood for investigation for CBC, urea creatinine, liver function test, clotting, and cross-matched at least 4 units of blood. 2 liters of crystalloid rapidly transfused as soon as possible, and when we need blood immediately we can give O negative blood if any delays in the cross-match. يعني إذا إحنا الكروس-match مالتنا يتأخر فممكن نعطي O negative blood without compatibility, because there's no harm for the anaphylaxis or allergy, in order to saving the life of the mother. Okay, what else? We put the infant, all of the measures we take it in order to enhance uterine contractions. For number 1, we can give it the uterotonic drugs. Number 2, we can put the infant to the breast to suck or stimulate the nipple manually. Prepare instrument and equipment such as sterile gloves, cannula, قلنا wide bore cannula, IV sets, catheter, etc. And administer the uterotonic drugs, oxytocin as ordered, and start the IV infusion and oxytocin drip, and emptying the bladder in order to enhance the uterine contractions. We have a very important measure in order to decrease and enhance the uterine contraction and decrease the postpartum hemorrhage, which is the mechanical stimulation of the uterine contractions. We have many methods and many many methods in order to do such mechanical stimulation. Number one, massaging of the uterus through the abdomen and by manual compression. Number two, to increase mechanical stimulation with balloon tamponade. And number three, intrauterine packing. How can do all of these? We can see this. This is the massage is very easy method. We can put our palm of the hand and try to do a massaging of the abdomen above the uterine corpus, like any massage we're doing. Number two, which is most intense and will enhance more the uterine contractions, is the bimanual compression. We put one hand, as you see in this picture, hand of the operator, right hand of the operator inside the vagina, on the till the cervix, and try to compress the uterine wall against our hand. On the other hand, we put it on the abdomen of the patient and try to compress the uterus like a pad in between our two hands, the left and right, and in order to enhance contractions and decrease the blood loss. This is the other method for the enhancing or for the doing the bimanual compression. Like this, we put all of the hand and try to compress the anterior and posterior uterine wall by the hands, by the fingers and the thumb, and the other hand on the abdomen of the patient in order to compress the uterus against of these two forces. The other, in order to decrease blood loss and enhance uterine contractions, we put a large 3 pads, okay, inside the packs, large packs, 3 inside the uterine cavity, like this, by the sponging, and all of these with other, okay, closed with other, okay. Then we will decrease the decrease the blood loss and increase or enhance uterine contractions and retractions in order to decrease the bleeding. The other, the uterine tampons, the way of decrease or enhancing uterine contractions, it play as a tampons or as a pressure on the anterior and posterior uterine wall in order to stop the bleeding from the sinuses and spiral arteries, and that's why it will decrease the uterine bleeding and enhance uterine contractions. And by this way we'll decrease the amount of blood loss. All of these measures we can do it in the labor room, okay. If all of these measures will be failed, we can do another methods. We will shifting to the surgical method. We will shift the patient to the theater, because the measures in the labor room will be failed, okay. If massage and agents are unsuccessful, we will we will shift the patient to the theater, and we give her general anesthesia and open the abdominal wall, and then try to ligate the uterine arteries bilateral in order to decrease the amount of blood loss. Then ligate the hypogastric arteries or internal iliac arteries. We can do a selective arterial embolization، بالحقيقة احنا ما موجودة عندنا. And we can do abelian sutures, which is called compression sutures. Of all measures for the decrease and stop the bleeding failed, we can do a hysterectomy. The hysterectomy is the last resort of the our last action we can doing in the cases of postpartum hemorrhage due to uterine atony, but we must taking into account the degree of hemorrhage and the overall status of the patients and her future childbearing desires. يعني if we have primary gravida and all of these things will be filled, we can manage as a hysterectomy, but when we are couldn't to save her life, we can try to saving her life as much as possible, because this is the because her child bearing desire is still present. Okay, يعني هي primary gravida عندها only one child، فالمفروض احنا we can try to restoring her uterus as much as possible. But if the condition will يعني threatening her life, we cannot stay more, and we must do a hysterectomy for her in order to saving the life of the mother. Okay, yes. Then احنا we started by the conservative measures. We started by mechanical stimulation and uterine massage, or we can do another rather than uterine massage, we can do a bimanual compression as we mentioned before, and we see the pictures. And we must give the uterotonic drugs. We call it the oxytocin, methotrexate and prostaglandin. All of these in combination. يعني نسوي المساج ونسوي البايمانوال compression وننطي اليوتروتونيك drugs. إذا ما فادتنا لازم شو نسوي intrauterine packing in order to decrease and enhancing uterine contractions. If it is not effective, it will put the uterine tampons, and as we see before in this picture. If all of these measures in the labor room, which are a conservative treatment, not successful, failed, we will shift the patient to the theater. We must do all of these within minutes, because we can lose the patient within minutes, okay, because there's a bleeding, there's a vascular shock. So we must do all of these measures in very quick phenomena in order to saving the life of the mother. And if we failed, all of these measures failed, unfortunately we must shifting to the hysterectomy, which is the last resort for the saving the life of the mother because of the uterine atony not responding to any all these measures. Okay, this is the billion sutures, or we call it the compression suture. This is act as like the bimanual compression, but by suturing. You can see how can we regarding this lady have cesarean section. Okay, this is a lower segment cesarean section, and when do the suture we must do below the level of lower transverse cesarean section, and try we put the thread here and try to transfer it above the uterine corpus to the posterior wall of the uterus, and we insert it here in the uterosacral ligaments, the right side and the left side, and then try to transfer it above the uterine corpus in the other area in the left side, and then put it here below the level of the lower transverse cesarean section, and then try to do a tight knot in order to compress the uterus like a bad. Okay, this is a compression suture, and we call it B-Lynch sutures. Okay, another cause of the postpartum hemorrhage, which is the second cause of it. قلنا الميجر هو اللي هي 90% هي uterine atony. السكند هو التروما اللي هو laceration of the genital tract. What are the causes؟ احنا حكينا عن الكوزز اللوكال والجنرال فاكتورز بالنسبة لليوتراين اتوني. رح نجي نحكي على الكوزز مال التشو او سوري التروما. because هو either instrumental delivery like forceps or manipulative delivery like breech, extraction, or prostate labor, or macrosomic. All of these may lead to what? May lead to genital tract trauma. طبعا we have types of trauma, either perineal laceration or vaginal or cervical. Okay? Yes. This is a type of cervical laceration, and how can we suture it? Later on we will discuss about it. We must know the perineal and vaginal laceration and how many degrees we have. We have a first degree tear when it is involved only the skin and minor part of the perineal body. A second degree when involved the perineal body and the vagina. The third degree tear when it is involved the anal sphincter and anal canal. Okay, this is the degrees of the perineal injury. Okay, yes. And how can we manage? And the management the same like the postpartum hemorrhage, how we call it for help, and we must do the ABC. We put a cannula and two whiteboard cannula and send blood for investigation and cross match, and then try to correct or try to stop the bleeding by the correct the injury. How can we correct it? By repairing. If the cervical laceration is more than 2 centimeters in length and actively bleeding, we must repair it and repair all the lacerations of the vagina and the perineum. And we can see this is the cervical laceration. When we repair it, we must do from the apex of the injury, because the apex is highly vascular area. And if we miss the apex, that's mean we didn't make anything, because the apex is highly vascular. When do the suturing here, it is not effective like this, because this is the major. هذا الأبي مال bleeding. Okay, فلازم we must suture it and must stop it, and then we will stop or we will repair the rest of the injury. This is the cervical laceration. We can do in the theater or we can do in the labor room. If it is low down, we can do it in the labor room. If it is high up, we must do it under anesthesia in order to repair it in a good way, in perfect way. Yes. This is the first degree perineal tear or first degree vaginal. This is just the involvement, the skin. When it is involved the skin and subcutaneous tissue or the vaginal wall, we call it a second degree. When the canal is considered as one canal, the vaginal and the anal canal, this is the third degree. When it is the sphincter is damaged and damage to the vaginal wall. Okay, all of these must repair it after the general measures we take it. Okay, we will transfer or we will take another cause of the postpartum, which is important. It is a tissue. When retained placental tissue, okay, retained inside, okay, it will lead to postpartum hemorrhage. After separation and explosions of the placenta is caused by strong uterine contractions, placental tissue may remaining inside the uterus prevent adequate contractions and predispose to excessive bleeding. Okay. What are the causes? The causes, usually it is morbid adherence of the placenta because of previous cesarean delivery, prior uterine curettage. It will affect the implantation of the placenta. The implantation will be not ideal. This will lead to morbid adherent of the placenta to the uterine wall. It will lead to partial, not complete separation. That's why it will lead to postpartum hemorrhage. Another who section saturate placenta, when the placenta will be delivered, but there is a section-saturate loop will be retained inside, it will lead to bleeding. طبعا types of placenta أو type of morbid adherent placenta عندنا 3 types. عندنا الأكريتا والإنكريتا والبريكريتا. What mean by the أكريتا? أكريتا when it is adherent to the decidua. When there is morbid adherent to the decidua, it will call it the placenta أكريتا. When it is adherent to the myometrium, يعني invasion واصل المyometrium, we call it إنكريتا. When the invasion is through the myometrium to the peritoneal covering of the uterus, it will call it the placenta pericrita. طبعا هذه it is the most dangerous type of the placenta, morbid adherent placenta, and usually it's ended by hysterectomy usually. طبعا هذه وتقريبا second one يعني بالنسبة للريسك عندنا الانكريتا، بس الأكريتا عادة خصوصا إذا كانت partial عادة ما تنتهي المريضة بهيستركتومي. طبعا later on we will discuss it by in the subject of placental of retained placenta. This is a accentuate loop that تلاحظون there is anastomosis in between the major part of the placenta and this loop. When this vessels damaged, bleeding will be happened, and this may lead on this is retained inside, it will affect uterine contraction retraction, and this will lead to postpartum hemorrhage. This is a tissue cause of postpartum hemorrhage. هاي هنا مطلعين placenta أكريتا أو إنكريتا أو بريكريتا، يعني morbid adherent placenta. Okay. طبعا prevention is better than treatment. The placenta should be examined to see that it is complete or not. Part of the placenta is missing, removed digitally. Not separated, manual removal of placenta is done. Hysterectomy is required for placenta incrita, pericrita and ecrita with the use of uterotonic drugs. فلاحظتوا إذا كان طبعا هم نفس الحالة، إذا صار عندنا bleeding هم نتبع ال ABC و call for help ونحط wide bore cannula ونسحب blood for cross match and investigations ونعلق crystalloid ونحاول part of the placenta يا ما نطلع manually، يعني part of the placenta إذا صار بيرتين نطلع digitally، أو إذا all of the placenta صار بيها retained نطلعها manual separation of the placenta. وإذا كانت أكريتا أو إنكريتا أو بريكريتا طبعا hysterectomy is done. بس طبعا all of these measures should be done under the effect of uterotonic drugs, uterine contractions drug like oxytocin, methargine and pitocin and prostaglandin. Oxytocin, methargine and prostaglandin. Okay, yes. And this is the picture, how can you remove the placenta manually when it is retained all of it. We follow the cord by the operator hand and start to separate the placenta step by step إلى أن نوصل تقريبا للفندس. We separated all of these and try to remove it digitally. Okay. Yes. The fourth T of the cause of the postpartum hemorrhage. احنا لازم نعرف انه لحد الان احنا بدنا نحكي على البرايمري postpartum hemorrhage. Okay. اللي هو happened within 24 hours after delivery. Another T اللي هو الثروmbin deficiency او coagulation defects. It is acquired abnormality in blood clotting. May be caused by abruptio placentae, amniotic fluid embolism, and severe preeclampsia or HELLP syndrome. Or may be due to congenital abnormality in blood clotting like thrombocytopenia, severe hepatic disease or leukemia. طبعا it will lead to DIC اللي هو disseminated intravascular coagulation if the bleeding is persist in spite of all others treatment described. يعني احنا حاولنا نشوف إذا أكو أتوني، إذا أكو tissue damage يعني trauma، إذا أكو tissue retained، زين لا كلها كل الكوزز بحثنا عنها ووجدنا لها. ممكن يكون الكوز هو ثرومبين ديفشنسي، يعني وصلت المريضة لمرحلة الدي اي سي، خصوصا اذا كان عندها ريسك فاكتور واضحة، كانت مثلا سيفير بي اي، كانت هيلب سيندروم، كان عندها اي تي بي. Okay, described DIC should be suspected. The blood passing from the genital tract is not clotting. Shock may happen because of reduction. Shock may happen because of bleeding. It will lead to reduction of effective circulation, inadequate perfusion of all tissues, oxygen depletion, and depression of function. Okay, طبعا we must put the patient under observation, chart recording for the pulse, blood pressure, maternal heart rate, central venous pressure, urine output and temperature. Lab test is very important. Hemoglobin level by CBC, bleeding and clotting time, platelet count قلنا بالCBC, fibrinogen level, prothrombin time and partial thromboplastin time. Fibrin degradation products is very important حتى نشوف الديجري مال DIC, and women grouping and cross match. طبعا التريتمنت is very important. The key is correcting the coagulation defects. طبعا لازم نسوي correction، يعني إذا كان عندنا مثلا نسبة الفايبرينوجين ليفل قليلة لازم نعوض فايبرينوجين. البليتلت إذا قليل لازم نعطي بليتلت. إذا مثلا تحتاج blood we give her blood. Resuscitation must be started as soon as possible. Infusion of crystalloid اللي هو saline and dextran is started firstly while arranging the blood transfusion. Blood transfusion is essential. Infusion of platelet, fresh frozen plasma, fibrinogen degradation product and clotting factor is very important in order to decrease the bleeding and correct the condition. So what are the potential complications of postpartum hemorrhage? Postpartum infections, anemia, transfusion hepatitis, Sheehan syndrome, Asherman syndrome. The best management of postpartum is prevention, as we mentioned. So now we will finish all of the treatment modalities and methods and causes of the primary postpartum hemorrhage. Then we started by the secondary postpartum hemorrhage, which the hemorrhage happened after 24 hours after delivery till 6 weeks. This is occur in more than 24 hours after delivery of the child. It is usually caused by the retention of the piece of the placenta or membranes and frequently complicated by intrauterine infections with pyrexia. Ultrasound examination will show whether there is a retained placental tissue. إذن نتوقع major cause of secondary postpartum شنو؟ retained placental tissue. لأن sometimes the placental tissue تبقى retained وما سوينا بالبداية bleeding بس later on سوينا on and off bleeding إلى أن توصل مرحلة إنه تسوي severe bleeding not stopped. Okay. طبعا cause of secondary postpartum hemorrhage هو infection, retained placenta, trophoblastic disease, persistent trophoblastic disease. احنا it is happened after antecedent pregnancy لكن أقل percentage من المولر pregnancy. زين we must giving antibiotic and resuscitation, correction للhair condition, and then evacuation of retained product if bleeding it persists or a significant amount of tissue retained inside the placenta. يعني ممكن التريتمنت just conservative بس لا إذا بقى البليدنج still persists where the condition cannot be improved, we must do evacuation after resuscitation. طبعا الكلينيكال مانفستيشن نشوف sudden episode تجينا المريضة of bleeding with bright red blood of varying amount. نشوف اليوترس sub involuted بنشوفه راجع للنورمال size. Patient may come with sepsis and anemia. طبعا how can we do a nursing management? Follow the same step as in cases of postpartum hemorrhage due to retained parts of placenta. نفس الفكرة. In case of postpartum hemorrhage due to infection, the following should be done. Reassure the mother, monitoring temperature, pulse, rate, and blood pressure. Start IV infusion and blood transfusion according to the doctor's order. Prepare sterile instruments and equipment needed for examination, emptying the bladder, administered medication as ordered, broad-spectrum antibiotic, follow strict aseptic technique while providing care to the woman, frequent changing of sanitary pads. And thank you very much and good luck.